Welcome to this explainer. Today we're going totally interactive to master some of the most confusing acid-base and electrolyte disorders out there. Seriously, if you've ever stared at a metabolic panel and felt a sudden wave of panic, you are absolutely in the right place. Okay, let's dive into this ultimate medical gauntlet. We're going to break down these complex cellular defects into a fast-paced, highly visual challenge.
So here's how this is going to work. We're going to tackle 3 high-stakes clinical traps using the exact friction points you need to know for the wards. No fluff here, just the pivotal labs and vitals that split these diagnoses right down the middle. I'm going to present a vignette, and I want you to literally shout out your answers before the big reveal. Let's see if your clinical reasoning is sharp enough to survive.
All right, let's kick things off with round 1, the normotensive alkalosis trap.
Okay, picture this. Your very first patient is young and presents with profound muscle weakness. You check their labs and you see severe hypokalemia along with a metabolic alkalosis. Naturally, you immediately check their vitals, expecting them to be hypotensive. But wait, their blood pressure is completely normal. They deny taking any diuretics and they haven't been vomiting.
Now, both of these genetic tubulopathies share these exact vital signs in blood labs. They both cause salt wasting, which leads to volume depletion, firing up the renin-angiotensin-aldosterone system. That secondary hyperaldosteronism drives the potassium down and the bicarb up, all while keeping the blood pressure seemingly normal. So I need you to make a choice right now, based on this friction point. Is it Bartter or Gittleman syndrome? Shout it out.
We definitely need a tiebreaker here, so we order a 24-hour urine collection. And this liquid gold reveals a massive calcium level of 350 milligrams. This severe hypercalciuria proves it. It's Bartter syndrome.
You know, what's really cool is how the physiological mechanism perfectly explains this divergence. Bartter syndrome essentially acts like a permanent loop diuretic. It hits the thick ascending loop of Henle, destroying the NKCC2 transporter. Because you lose the positive luminal charge normally generated right there, calcium just cannot be reabsorbed paracellularly, and that drives the hypercalciuria. Gittleman, on the flip side, mimics a continuous thiazide diuretic. It hits the distal convoluted tubules NCC transporter, which actually enhances calcium reabsorption, causing hypocalciuria. So you get the exact same blood labs, but totally different calcium clearance.
Moving right along, let's dive into round 2, the hypertensive hypokalemia trap.
Here is your next vignette. A young patient gets referred to your clinic. They have severe hypertension that is just not responding to standard medications. Their labs show the exact same potassium and acid-based arrangements as round 1, hypokalemia and metabolic alkalosis. But this time, their blood vessels are clamped down tight.
This is a really serious diagnostic trap. The classic triad of hypertension, hypokalemia, and metabolic alkalosis screams aldosterone excess. But is this an adrenal tumor pumping out aldosterone, like in primary aldosteronism? Or is it the genetic mimic Little syndrome? What do you think?
Boom. We check the peripheral plasma renin and aldosterone levels, and we find extremely low renin and extremely low aldosterone. The adrenals are totally suppressed, which confirms this is Little syndrome.
So, the crucial point to remember here is that Little syndrome features an inherited gain-of-function mutation in the epithelial sodium channel, or ENaC, in the collecting duct. Specifically, these mutations delete a highly conserved PY motif on the channel. Because of this missing piece, the ubiquitin ligase NED4-2 cannot bind to degrade the channel. The result? The sodium channels are constitutively stuck open on the cell's surface. Sodium just floods in uninhibited, causing massive volume expansion and hypertension, which then completely shuts down normal renin and aldosterone production. It's basically a massive fake-out of primary hyperaldosteronism.
You have officially survived the alkalosis traps. Welcome to round 3, the RTA acidosis showdown.
Okay. We've got a patient suffering from a normal anion gap metabolic acidosis. We call it NAGMF for short, combined with severe hypokalemia. The chloride is sky high, compensating for the drop in bicarbonate. Now, we've already ruled out GI losses like diarrhea, meaning the kidneys are the culprit here. You have to distinguish between the top 2 hypokalemic renal tubular acidosis here. We know type 4 RTA is out of the question because that causes hyperkalemia. So is this a proximal type 2 or distal type 1 RTA? Let's see if you really know your nephron geography. Make your call.
The labs return a urine pH stubbornly stuck at greater than 5.5 alongside a positive urine anion gap. That totally locks in the diagnosis of distal type 1 RTA. Even in the face of severe systemic acidosis, these kidneys just cannot drop the urine pH.
Let's look closely at the cellular defect. Type 1 distal RTA involves a complete failure of the alpha intercalated cells in the collecting duct to secrete hydrogen ions. Often, this is due to genetic defects in the H+ ATPase pump. Because they literally can't pump acid out, the urine stays abnormally alkaline, staying above 5.5. Type 2 proximal RTA, however, is a failure of the proximal tubule to reabsorb filtered bicarbonate. The distal tubule still works perfectly fine in type 2, meaning once the blood bicarb drops low enough, the distal tubule absolutely can and will acidify the urine below 5.5.
All right, you made it to the end of the gauntlet. Time for the final cheat sheet.
Get your cameras ready, folks. You're going to want to take a screenshot of this rapid-fire visual summary table. It perfectly compares the crucial friction points across all 5 of the complex disorders we just conquered in this explainer. Notice how blood pressure separates Little from Barter and Gittleman. Notice how acid-base splits the RTAs from the rest of the pack. And look at how urine calcium is the ultimate deciding factor between Barter and Gittleman. This table right here is your master key for unlocking renal tubulopathies on the fly. We've literally just seen how tiny, microscopic changes, a missing PY motif, a faulty H+ ATPase pump, a broken chloride channel, manifest as massive, life-threatening systemic electrolyte storms. So as you take this newfound clinical reasoning out into the real world, ask yourself, armed with these friction points, which of these hidden cellular defects will you be the one to catch before it's too late? Thanks so much for joining this explainer, and stay curious.